All right, everybody. Hi, hi, hi. Believe it or not, I'm actually going to have the quizzes done for lab. And I'll have the exams for lab so you can look at those there. And we'll get that organized because we'll do the heart dissection in the lab. And so I'm trying to get back on task because I had 3 weeks of feeling lousy has finally got to start to end. Nevertheless, here we go. So I want to finish up a little bit today with the heart portion and the heart physiology, and particularly this particular image that you just saw and the one that follows it over here are really the secret sauce to understanding what's going on in the heart. So I want to amplify those a bit for your pleasure. And then we'll go and start going into blood vessels, which is the next unit. The lab portion is really identification, the names of the blood vessels in the different regions. But understanding the makeup of the blood vessels is important because there's a fair amount of physiology vis-a-vis blood pressure, modifications in circulation that we do with regard to the blood pressure unit. And then once that kind of concludes, I think the information, I'm trying to think of where we did endocrine. So blood, heart, and blood vessels, probably the information for the second exam. Did I send you the study guide as yet? No? Yes? Maybe? No. Okay. I'm on it. I will take care of it. And then we'll figure that out. Typically, those come toward the latter part of this month. And then inevitably, there's something prior to Thanksgiving, and then we have to find. That's usually the saga. You guys you're veterans, you're already used to this kind of stuff already, right? Right? Hey, seen this movie before. We know how it ends. Just saying. All right. So pardon me if I keep looking at this. One of our kitties has gone missing. He's an outside cat a lot of the time anyway. We can't seem. Maybe he found somebody else to live with. So I was hoping that he would maybe be showing up when he's hungry. He's done this. It's not the first go round. I'm kidding. Nevertheless, so this is really it's spoken. The next illustration actually I think is a little bit better because you can see more of it with the cycles. But I did want to address this part first. It's the heart sounds. So heart sounds is what they're pointing to here, and notice where they occur. If you look at the cycle itself, you obviously can see the cursor that's there. The first and loudest heart sound is what happens when the atrioventricular valves, the tricuspid and bicuspid, slam shut. They do that shortly after. So you'll see the events because they'll have the electrocardiogram with it. But effectively, what is happening? This is the start of the cycle, roughly here. You have passive filling, okay, that's going on in between heartbeats. And then what starts this atrial contraction, as you'll see in the next slide, comes directly after the P wave. Again, electrical events precede mechanical events. So the P wave will occur, and that will permit basically topping off the ventricle. So you can see their volume will increase. At that point, and again, you'll see it when you'll see the electrocardiogram, that there's enough time for that filling, and then the QRS complex occurs. That means the ventricles are firing, and they're much more aggressive. They're not a slow kind of passive squeeze of the atria. The ventricles really ramp up. And the first thing they do is they ramp up the pressure. And the fancy term for it is isovolumetric contraction. That's a nice way of saying we're not adding any more liquid. We're just going to squeeze. So once they start to squeeze and build up the pressure of the liquids in there, it slams those doors shut. Remember that the valves are kind of pointing down this way, and then boom. So assuming they're functioning properly, they slam shut. That's the first heart sound. Then the pressure ramps up, and it ramps up until such time as it can overcome the resting pressure in the aorta. And so the resting pressure here, once it starts to get to there, then eventually what's going to happen is going to get high enough to make ejection pressure. And what you're going to see, once it overcomes the resting pressure and reaches that point, roughly that 120/80, and we're looking at the 120 part, that's called the systolic ejection pressure. And I just went backwards. what will happen is that you're going to see the volume is going to go down because it's going to start to eject the blood very rapidly. And then there's going to be an interesting phenomenon here called the dicrotic notch. And effectively, the way I look at it, normally, if every time our heart pumped and nothing happened in between, we'd have a lot of blood flow, then blood flow will go down. A lot of blood flow, and I'll get another marker, and then it will go down. That's very much, even though the word I'm using is pulsatile, that's a rather turbulent way. Let's see this question. Oh, so that's rather turbulent. And turbulence equals a chance for blood to clot. And when you look at this illustration here, what happens with a dicrotic notch is this. It begins to reach a pressure, then the blood begins to reach, and magically there's this notch that kind of does this. And what it does is it creates a more uniform amount of blood flow. And it prolongs the blood flow. It allows it to get from our heart all the way down to our toes. Let's look at it that way, even with the assistance of gravity. But what it avoids is that rapid up and down, up and down. So that dicrotic notch is not on the cardiogram. It's not associated, but it's associated with a particular heart sound, because what happens is those blood vessels you're going to see in the next chapter, the aorta, the pulmonary artery, those vessels are elastic arteries. They're very, very stretchy. They're like a trampoline. When the blood flows into it, they expand rapidly, and then once the pressure wave starts to decrease, they rebound, just like it would on a trampoline. So you stretch it out, they're going to start to come back. When they come back, the blood that's in there. So you'll have, here's this big artery, all filled with blood, and when it comes, when the walls start to come back to normal after being stretched way out to here and here, it's going to force the blood. If you have any liquid like in a straw and you squeeze it, it comes out both ends. So it's going to increase the blood flow, all what you're seeing there. But what neatly happens is it pushes back over here. And again, here are the valves. And it slams those valves, the aortic and pulmonary semilunar valve, shut. And that creates a backflow. So it's what happens. It's sort of like a wave coming into the shore. It hits the shoreline and it comes back out. Same kind of deal here. And what that does is that increases a secondary pressure that kind of creates that dicrotic notch. So we see the second heart sound is just as that's beginning to occur, and shortly afterwards, increased flow. That's the beauty of the heart. This interesting arrangement. And we see it there. And sometimes you get lucky. We do a lab with the technology when we do blood vessels. Earliest possibly would be next week, where maybe we can see that dicrotic notch, because we have like a blood pressure cuff, and you can to some extent measure the flow. That's there. And again, I'll need volunteers. You don't have to volunteer again. You've already checked that off your check sheet. Was that set thing you guys have, like all those things to crazy? Do you like that? Does this make any sense? We didn't do that in college. I mean, I realized it was a long time ago in a galaxy far away. You went to class, and if and other than my first 2.5 years where I really didn't go to class, you took the test, you interacted, that was it. Didn't do any community service, didn't travel extensively. Well, the class came back. A lot of that was a very turbulent time. There was a lot going on. Do you have grandparents of that age? Right? Did any of them go to school in that circa right after Woodstock period of time? Anybody got a 72-year-old grandmother or grandfather? See? Ask them. If they were in college at the time, and not everybody was, most of us were experimenting with substances that we probably should not have used. Statute of limitations has expired. And now in a lot of cases it's legal, or you can get a medical card for it, just saying. I digress. But we still managed to get through. So this is the big picture. So P wave, QRS, T wave. So you can see what's going on there. Now, so when we look at this greenish kind of a line, okay, that represents the pressure in the aorta. That's where you see the dicrotic notch. So when the heart's at rest, the pressure goes down to whatever its resting level. The resting level is called the diastolic when you're talking about muscles and vessels. Diastole is a period of relaxation. What it represents, and this is super important, that bottom number on your blood pressure, not yours, on my blood pressure, is the significant factor when it comes to high blood pressure. That's called the resting tension. So when your blood vessels are overly tense with high blood pressure at rest, like say 90 or 95, that means your heart has to work extra hard to push the blood through. That puts a strain on your heart. That's bad. Okay. Because there's, it's over, and it's really something that occurs over long periods of time. That's the real tragedy of high blood pressure, and it's like a lot of systems biologically in our bodies, we don't notice a problem until it's 5-alarm fire. You'll hear me say this again and again. Whether it's respiratory, whether it's kidney, whether it's gastrointestinal, everything works fine until all of a sudden all these backup systems fail almost simultaneously. So why we call high blood pressure a silent killer is it'll be ramping up, and the pressure will be greater, and all of a sudden the heart will work so hard, there's a heart attack, or the heart will work so hard, and one of the blood vessels will pop, and all of a sudden you'll get a bleed, or you'll develop an aneurysm, and all of those things potentially could be fatal. That's the interesting thing about that. That's why that bottom number. So basically we look at that one. So my wife went to, yesterday morning, she had a doctor's appointment, and her pressure was 120/60. And it's not unusual for women to have lower diastolic numbers, and it's always good. Okay. So that was her tested there. Because of that, basically you'll see there's a formula where you measure the difference is 60, you divide by 3, 20, and you add the 20 to the 60, and you get what's called the mean arterial pressure, which is the number we kind of look at. And hers 80 is fine. 80 to 95 is 80 to 100 is fine. So that's the kind of thing that you look for. And my wife is 65 years old. She's in considerably better shape than I am, and doesn't take as many pills and anything along those lines. That's kind of that's why you become so much more interested over time and things like that. So that's the first little nugget. So that demonstrates the resting tension, and that has a lot to do with your overall health. And you can see once we get into what we call the cycle. So the other numbers are here. So in blue, basically what you're seeing is the red is the pressure in the atria. There isn't much. So the atria are really at rest. They're passively filling. There's not a lot of pressure. The only time there's a little pressure nugget that increases is when we kind of basically fill, is that right after the P wave, and it adds, and it pumps a little extra blood into the ventricles. But the ventricular pressure, again, very low, gets a little boost, and all of a sudden it ramps up after that first heart sound, when everything gets squeezed and it's building up this pressure head that eventually overcomes the pressure that's holding those valves. Because at this time, and they used to show that here, at this time, and you can see it a little bit here, the atrioventricular valves are open. That allows passive filling. But the semilunar valves up here are closed. And it isn't until we overcome that pressure in those valves that pushes them open that we begin to get blood going back toward the lungs and the pulmonary artery, or back toward the rest of the body in the aorta. So, and that's the signal when all of a sudden that pressure jumps down, the volume rather jumps down, but the pressure is extended because of what I demonstrated before with the atrioventricular valves closing. So you can take a look. This is the volume that's there. So you have your volume is gradually increasing in the heart, and then all of a sudden drops down once it's pumped out, and it just starts rising again. That's what we want to see. Again, nothing that's overly pulsatile, either here or here. That's the first. So here, that's really, to me, sort of the marriage of the electrocardiogram, the heart sounds, and what's going on in the heart itself. And explaining that interesting thing called the dicrotic notch, which is about pressure, has nothing to do with electrical activity or sound that are there. So the first sound, the louder of the two, the AV valves at the beginning of the ventricles getting ready to pump. The second sound, now, because when it pumps, it's open those semilunar valves. And so when the ventricles relax, it allows the pressure wave to go out of those, as you will see, elastic arteries, and we get the second one. So, and in between those, your heart's relaxing. Mitral slightly before, again, and you saw that illustration before about the area when people listen to the heart where they're able to do that. Like, again, I didn't have it. There's that illustration. Murmurs, abnormal sounds, and there's different sounds for different murmurs. We have good ways of finding them out once you analyze a murmur. The typical test, and maybe you folks are in this test, those of you who are doing the nuclear medicine or related studies. Do you do ultrasounds as well? Okay. The ultrasound is sort of is a test that's used a lot. They call it echocardiography because sound waves are just that. So if somebody's pregnant and they're going to do sonography, basically that's high frequency sound waves, and sound waves bump off different things. The denser something is, it reflects the sound back. The less dense the sound goes through, and it sets up a different echo pattern. It's like in a submarine when they shoot out sonar and you're waiting for the reflected wave to come back and analyze the pattern. Basically the same thing. And ultrasonography has been around. We used ultrasound in physical therapy because what it does is it goes through your skin and the soft tissue and bounces off bones and joints and ligaments and muscles, thick stuff. And it causes, that vibration generates a certain amount of heat. So it's used rehabilitatively for people with bone, muscle, joint injuries. Athletes do it a lot, that kind of a thing. So the ultrasonography has been around for a long time. We also use that technology in the blood. There's a thing, and maybe you'll see it, maybe you won't, it's called a Doppler. The Doppler is, it looks like a stethoscope, and it's got a little power pack, and you're listening in your ears, and you put the tip of the stethoscope on blood vessels, and you can actually hear the whooshing of the blood, and you listen for the sounds. And it can be done directly that way, or you can feed it through a machine. There's all sorts of ways for vascular analysis. And we did a ton of that stuff. A friend of mine who's no longer with us, I mean, he had a whole big unit in his office testing diabetic patients for blood flow and analysis like that. So what we look at is different kinds of sounds. And again, I can't be the one to tell you about them. They don't close. There's backflow. Here's a swishing sound. The blood kind of regurgitates. If it's too narrow, then you can imagine a high-pitched sound. It's trying to squeeze through an opening and making a louder sound. That's there as it's forced through a narrow valve. And then this is really what we evaluate. I talked about it a little bit before. Cardiac output. The amount of blood, we call it, you could use the term, cardiac output implies the amount of blood that's put out in the space of a minute, and the typical numbers we use. This is the ejection fraction. Each ventricle holds about 4 ounces, about 120 milliliters. We eject 70 milliliters. That's really only about 57%, but it works just fine. That's very efficient. We have some blood that's left in there, and we do, when you crunch the numbers, you get 5.25 liters. And that should marry, when we get to respiratory, the amount of oxygen that you take in, something called a minute volume. So most time we inhale on an average breath between 400 and 500 milliliters, about 12 of those a minute. So now you're right in that same area between 4.8 and 6 when it comes to liters. So as you can see, in a non-athletic individual, any of us can ramp that up 4 to 5 times, and in someone who's trained 7 times. And that's the reserve, and that's just so important. So important. Okay, that's really what I commented before, that's what cardiac rehabilitation is about. Lowering your resting heart rate, making sure you have adequate circulation, so in times of stress or times of activity, because it's horrible. Every year, somebody my age, my kind of general physical condition, who's not done anything physical, the first time we get that wet snow in November or December, they go out there and shovel, an older person, and they have a heart attack. And sometimes they die. And just look at the newspapers or look online. You'll read about that stuff. It happens every year because now you go from doing nothing but being sitting around, and all of a sudden you do very very vigorous physical activity in very very cold temperature, which is why I go out there for like a half. Why am I not in Florida? Will you explain that to me? Did I show you the picture where my kids live in Jacksonville? I didn't. Remind me and laugh. Their backyard is the ocean. Why am I here? There's no reason. I should be there. I don't know how they're going to adapt to it when he has to go back to Northern Virginia. He's going to be back at the Pentagon by the summertime. They'll figure it out. Okay, so stroke volume and heart rates. And these are just the kind of things. You're going to learn a lot about venous return. That's really important because that helps to preload the heart without you having to forcibly do it. We learn about different things that make it more contractile and the changes between sympathetic, which causes it to be more aggressive, versus parasympathetic. So all of those types of things, and now you're looking at that, what they call that. So the big factors, loading the heart passively, how contractile, how the ability of the heart muscle to contract, and what's left in there. That's called the afterload. So all part of it. So the preloading, so muscles are like that. We have to stretch a muscle a little bit to optimize contraction. If you have too much, it's too hard to stretch. If you have too little, it's too hard to contract rather. If you have too little, it isn't stretched enough to generate any force. So when you have alterations in that, it affects how much stroke volume, how much blood you can pump out, and what's left in there. And a famous law called Frank Starling's law. So because cardiac muscles at rest, you folks sitting here now in between beats, are not really sufficient. They have to be stretched a little bit to work optimally. So the most important factor, venous return. That's why when we get to blood vessels, you see I'm more of a nut about veins in a lot of ways because that's really was my area of expertise, as much of that. So increased venous return stretches the ventricles, increases the force of contraction. That's all you have to know about Frank Starling. How independent muscle stretch and end diastolic increased contractility helps to get rid of the blood more effectively. So you lower what's left in the heart. Okay, lots of things do it. Epinephrine does that. Epinephrine increases the rate of contraction and the force of contraction. We'll get to some words about that right away. So when it's hear the term positive inotropic means force of contraction, and negative, so this increases it, this decreases it. What makes your heart contract more efficiently? So people who are hyperthyroid, there's too much, but thyroid hormone is necessary. Glucagon, which we put out a lot in fight or flight. Epinephrine, we put out a lot in fight or flight. A medicine called digitalis was used extensively before we had some better heart medications. So I don't see, anybody you knew with a heart condition was on digitalis 40 or 50 years ago. My dad was on it when he died back in 1988. So that it was a useful medicine, but it had its limitations. So it's not really as relevant now. And calcium plays a significant role as well. That's why we look a lot, and you'll learn about those, I suspect, a little bit down the road, called calcium channel blockers. What makes it less effective? Acidosis. Diabetics get that all the time when they're out of control. Irregular potassium levels. And then the calcium channel blockers are something, I take one of those for blood pressure because it affects calcium going into blood vessels, and the blood vessels kind of relax. And if you had a top 5 for blood pressure medicine, calcium channel blockers would probably be number 1. So anybody know with high blood pressure takes one of those. And they're just showing you the pathway. We're not going to go into that. What's left? Afterload. So if it's in there, the ventricles have to overcome that. There's back pressure. So hypertension increases afterload, resulting in increased end systolic and reduced stroke volume. So if you don't efficiently get rid of the blood, it's a problem, we would say. So there's other things we use when we talk strictly about heart rate. It's called chronotropic, like chrono means time. So positive increases, negative decreases. Most important of these is your vagus nerve through the autonomic nervous system. That's what lowers your heart rate. And then there's other agents, chemical agents and other factors, overall fitness, things like that, athletic training. So those are all part of it. And I don't think we have to go through that quite so much this. It's the distinction. You're in fight or flight, you generate epinephrine and norepinephrine. And what that does is increases the heart rate as well as other factors. And in the parasympathetic nervous system, which should predominate in the heart, effectively it works, releases acetylcholine, the neurotransmitter, which you probably learned about in AP1. And what that does is it lowers effectively, it hyperpolarizes, so it makes it harder for the heart to beat every time. So that's the vagal tone. So normally that has to predominate. And I say it all the time. Our systems are all about governance. Basically, our bodies go at a more rapid pace than desirable. And what your health does is it maintains that pace. You learned about the cell cycle in AP1, right? All those prophase, metaphase, anaphase, telophase, cytokinesis, ringing a bell, G1, S, and G2, and interphase. That's the cell cycle. The cell cycle would run out of control. A healthy individual has what they're called checkpoints. When those checkpoints don't work, the cell cycle goes crazy. It makes cells too fast. Whenever you do anything too fast, what are you likely to do? Make mistakes. And unfortunately, when cells make mistakes, sometimes they're cancer. Heart's the same way. Okay? We try to keep it under control. And that's the idea of vagal tone. So that's what we look for. Okay, I explained to you when you work on the treadmill or do any aerobic activity, whatever it is, it's very useful to have a target range for your heart and maintain it there. Most of the experts will tell you anyway, it's little, like 3 to 6 times a week for maybe about 30 minutes, maintaining that level. Unfortunately, walking the dog a lot is not sufficient. Okay. And there's other reflexes. Venous return plays a role. You don't have to know about the Bainbridge reflex. And it's the chemicals. Epinephrine and thyroid hormone increase it. It's different ionic concentrations. And really, the important statement is right here. Keeping those in the normal range. I showed you those blood tests. We look very closely at them. And I was very ill in intensive care 17 years ago. My potassium was so low. I mean, I was at my muscles were spasming, going irregularly. I was, when you're in intensive care, by definition, you're close. And they had to give me a lot of potassium, and it's not fun. So these are different things when we look at calcium and potassium, calcemia and kalemia for potassium. They all have different alterations. So we look, probably the bad combination would be excessive calcium and not enough potassium because of arrhythmias. And if you have arrhythmias and your heart is going too rapidly, it would be a very significant. And normally our heart rate declines with age. The fetal heart rate is very significant. Babies are born about 120. Females faster than males. Exercise, again, over time you can lower it. Body temperature increases it. By definition, 60 to 100 when we say tachy at rest, over 100, or slower than 60 unless someone is highly trained physically. What's the downside? This congestive heart failure. It's from the beginning, the way to frame the heart is you have two pumps side by side that are working simultaneously. They're both work fine if they're each pumping equal amounts of blood, whether it's to the lungs and the pulmonary circuit or to the rest of the body in the systemic circuit. As long as those two are coordinated, it's all good. The minute there's inequality, you're on a slippery slope to congestive heart failure. And so you're going to hear about things like that. When it's adequate circulation to do business, it's called well perfused. Perfused, perfusion. When there's insufficient blood flow to an organ or to an area, it has a very fancy name called ischemia. Ischemia. Words you don't. Ischemia is not a word you want to have. So, different things. Commonly, the heart itself is weak because of coronary artery disease from a lot of different things that are there. A lot of time it's fatty buildup, but it's not necessarily fats as much as you think. When we looked at diabetes, remember what happened when people had to use, they began to metabolize or break down fats because they couldn't utilize sugar. And then those fats were excessive and slammed together and formed ketone bodies or trans fatty acids. So it's not necessarily directly from a fatty diet. A lot of people, myself included, were much healthier doing the ketogenic diet, where because you're limiting the carbs, but you're utilizing fats that are in a way that they are quote unquote healthy fats that will pass fairly easily as long as you stay well hydrated and don't tend to form those trans fatty acids as long as you do everything you're supposed to be doing. There's a whole lot of nuances with regard to that. But certainly that's the big player. And a lot of times it comes out of nowhere. So my dad's the perfect example. Where in a matter of maybe a year's time, all of a sudden we went from vigorous and healthy to not being with us and not surviving open heart surgery. And my dad, unlike me, when he died, my dad was 6 feet tall, had a 32-inch waist, and weighed 182 pounds. Extraordinarily fit and trim. Was on the treadmill all the time, had one at home. Yeah. Go figure. So, persistent high blood pressure. So, when you have pressure, okay, that is over this, and we're going to look at this in the next unit with blood vessels. When you start to get that bottom number up, that really is creating a lot of force, okay? That makes that over time, the heart is working harder, but the heart enlarges, and enlargement isn't good. The muscles overly develop in the heart, and they're not as efficient as pushing out the blood. The blood comes in, it can't stretch it because the muscles are overdeveloped. It's like a bodybuilder. They're so imagine they can barely move their arms because the muscles are so large. If you see people in these, you know, these interesting bodybuilding competitions that look like, a lot of times it's almost overwhelming. That's there. If there's been damage from heart attacks, myocardial infarct means death of muscle tissue from lack of blood supply. This is less common. Sometimes it's viral, sometimes it's related to genetic defects, there's drug toxicities, cardiomyopathy. And this is unfortunately one of those things where the heart muscle just doesn't thrive. And now you're looking at transplantation if possible. But the problem with the heart failing is called congestive heart failure. Ultimately, it's a pump. If a pump breaks, there's going to be a backup of fluid. So it doesn't take, you don't have to figure it out. If the left side of the heart more commonly doesn't function well, the fluid can't come back from the lungs and it clogs up the lungs, pulmonary congestion. If it's on the right side, the fluid goes into the body, and edema is an accumulation of fluid effectively under the skin and the soft tissue layers under the skin. And so gravity tends to make that very, very apparent, particularly in the extremities, the lower extremity. And so what happens over time So if there's pulmonary congestion, now the right side has a hard time pushing fluid in the lungs because the lungs are filled. And the fluid's already in there is having a difficult time getting out. So now the right side works harder and harder until finally can't. And now it collapses. So eventually it seriously weakens both sides of the heart. So there's a lot that has to be done. It's very complex. And at the same time, you have to address other factors that are there. Because frequently, somebody with congestive heart failure, the first place you got to look is the lungs. What if they have emphysema? What if they have obstructive pulmonary disease? Why if they have some inherent problem with their lungs? Maybe their ability to expand the lungs as people get older, the cartilage is not as flexible, becomes somewhat bony. All those things are part of it. So it's a challenge. And for many of you, you're gonna deal with folks who have these things, and yeah, I get to be sensitive to it and understand there's certain degrees of limitation. Voila. We are done with the heart, other than dissecting it today, which would be fun. Which brings us to blood vessels. I didn't put that out yet. 18A. And yes, there's yet another handout that's part of that heart and blood vessel handout. Do look at those. A couple of people email me with questions post the exam. A lot of the material comes off of those sheets that you saw before. So just to amplify it, for instance, that heart outline and blood vessel outline here, all the stuff I've just been telling you, most of it's summarized here. And so that's the heart, and then the next one is blood vessels. I'll get to that. It's quite kind of long. Back pressure, and now chapter 19 used to be chapter 19, now it's 18. They changed the numbers. All this stuff, the vascular anatomy, the lumen, the various tunics, which is the older terminology, elastic arteries, that's the ones with the rebound, etc. It's there. Read it. There's no extra charge. See, when I went to school, everybody used to go, you all would go to the library to study. I'm not a library study. I would just spread out stuff everywhere, walk around, go crazy with it. Too quiet in the library. I was always getting thrown out. You're making too much noise. Blood vessels. We'll get to the lymphatic system as an auxiliary system that assists the veins. That is not, it differs significantly, not so much in its location, but its anatomy. So by definition, we learned this already, arteries. Doesn't matter whether it's oxygenated or deoxygenated blood, umbilical artery, pulmonary artery, carrying blood away from the heart. Capillaries, that's where the exchange goes on. Oxygen and carbon dioxide, nutrients and waste products. Whole ball game is a capillaries. So capillaries are, as you will see, they're very unique in the fact that there really is just like a tube made out of cells with a minimal amount of connective tissue around it that allows the exchange to occur. And veins, again, back to the heart. And so again, with those other two obvious exceptions, they carry deoxygenated blood. Why are veins important? Because you have twice as many veins as you do arteries. When you have a named artery, like your radial artery, your femoral artery, your superficial temporal artery, any of these arteries, you generally have at least two and sometimes three veins that go along with it. So venous return, something I was trying to emphasize when we talked about the heart. Years ago, when they were first starting to do replantation of limbs that were severed, terrible accident, somebody had their arm cut off, industrial accident, a big industrial saw. You could, and what they found out was putting the arteries together wasn't enough. For every artery you had to sew back together, you need 2, 3, or 4 or more veins. The more veins, the better. Because the biggest problem was blood not getting back and being stuck in that remaining portion of limb for that to occur. So there's been a lot of science, and we were just starting to see that when I was a resident. So I started my residency in 1977, and they were just starting to do a lot of that stuff at local hospitals. It was in Philadelphia, where I was there for 6 years. So, sorry, I survived. A lot of good eats in Philadelphia. A lot of good. So, moving on. There it is. Now, the lymphatic, you're going to see what makes the blood vessels unique is a closed system. So, meaning there's no, well, even at the capillary level, you can lose oxygen and bring back carbon dioxide, give up nutrients and bring back waste products. The vessels are continuous tubes. Even though as the vessels get smaller, you get more of them. The lymphatic system, which they have appropriately on the venous side, has an opening at its entry point and then eventually joins the veins. That's the difference that's there. And we do that because that plays a pivotal role in your immune system. It's also important for circulation, but it's really important for your immune system. So you can see it. We have the arteries that are close to the heart are these elastic arteries. That's the pressure head. That's the trampoline. The arteries that you'll learn the names of are mostly muscular arteries. And then as they get smaller, again, we use arterioles. Arterioles are really vessels where we can adequately control blood flow, because you're going to see they have enough muscularity to basically close them almost completely or open them relatively wide, where you don't have that luxury here and here. So you're going to see they're the pivotal players when it comes to blood pressure. And then a whole number of capillaries, and there's variations depending where they're located. So what's the sort of the uniform factor? They have a lumen. So LUMEN in any hollow tube, and this is the part of the program we learn all about hollow tubes, blood vessels, air passageways, digestive passageways, genitourinary passageways are a series of hollow tubes. The generic term we look for that opening in the middle of the tube is lumen. Nearly all of those tubes have lining on the inside, lining on the outside, and typically smooth muscle, with the exception of the heart, which has cardiac muscle. All of them have variations of smooth muscle. And smooth muscle is just that. It's designed to be relatively easily, not terribly powerfully, but consistently. They're more about sort of like slow and steady winning the race would be maybe the way to describe that. So you're going to see this pattern familiarly, except for digestive, 3 layers. You saw it in the eye. Remember, you had the tunica externa, and tunic was the old term for the cloak around it. So you had the external layer, the fibrous layer, the vascular layer, and the neurological layer. Not a whole lot different here, except these tubes, with the eye not being a tube, have a lining layer. Okay, they have a middle layer, the media. Intima means intimately associated with whatever it's in contact with, in this case, the bloodstream. Media, middle layer, smooth muscle, not cardiac. And externa, the externa is the firm layer that sort of holds it together. And there's a lot of nuances that are there. When we get to the capillaries, it's almost like you took a cell and a cell and you made a tube out of individual cells. They don't have the media or the externa, and that's what makes them very unique. What's interesting is about how the cells are put together. They're not most of the time there's little spaces between where the cells are, and that allows stuff to go in and out. And depending on the number of spaces and the size of the spaces, that categorizes the capillaries. So our British friends would say capillaries. Just ask I'm obsessed with British crime shows. Obsessed. So We're watching the 5th season of our favorite one called Unforgotten, which is about like cold cases from way back. Very, very good. PBS Masterpiece Theater. We got to get you guys some culture. So the intima, the innermost layer, contact with the blood. Its lining is the same as the heart. Endothelium, simple squamous lining cells. They cover the heart valves. They cover the internal part of the heart. I do this 8,000 times a semester, whether I drop the pen or not. Smooth, it does that. It's turquoise. That's the intimate 101. Stuff slides over it. Easy. It's all that lining is all about that. A delicate coating that's on there. Right? So simple squamous epithelium that lines the lumen, continuous with the endocardium, as well as the lining of the heart valves. Slick, reduces friction. Easy. Underneath all linings, under all epithelia, there's a small layer of loose areolar connective tissue. With the exception of vessels that are smaller than 1 millimeter. Once they get super small, we don't quite see it as much. But by and large, it's there. And that's an important area when you hear about vessels being clogged, like coronary artery disease, that's where it occurs. The coronary artery disease, it settles in that layer, these accumulations of fatty tissue, and they become inflamed. And what they do is they separate the lining cells and expose the undersurface, which is filled with collagen. And that's what allows the blood to clot when it comes in contact with collagen. So the middle layer, smooth muscle, and in blood vessels, depending on their size, sheets of elastin. So that's the stretchy. That's what you're going to see. There's an abundance of that in certain structures. The only nerve control of blood vessels is sympathetic. The parasympathetic that slows your heart, accelerates digestion and genitourinary function, all of those things, causes glands to secrete, has no role in the diameter of blood vessels. So it's all controlled by the sympathetic nervous system, which is very, very interesting in and of itself. And so it does one of two things. When it fires, it constricts them, vasoconstriction. And when it stops firing, it dilates. And that's one of the ways we shunt blood to where it needs to be. When you and I are sitting here, like we're doing, we're at, relatively speaking, at rest. Our blood is mostly going, other than the areas it always has to go to, is mostly going to our gastrointestinal and genitourinary systems. Okay. The sympathetic system is, relatively speaking, inactive. Okay, so the parasympathetic system, even though it doesn't involve the blood vessels, is really in charge. It's called the rest and digest system. You might remember that. So that's blood pressure and blood flow. When you'll see that dramatically changes if you go out, in the minute you start to walk from this building to the next, all of a sudden it's going to start to change. The blood flow will get redirected to your heart and to skeletal muscles because you're using them. Body's very good about that. The externa, the outer layer, the third layer, okay, and it's just, in the old days we called it the adventitia, collagen fibers reinforcing. This holds everything in place. And there's a lot of places where nerves and other vessels enter. And the fancy name is called vasa vasorum. Vessels to vessels. Big, thick arteries need a blood supply of their own to function. Big, thick nerves have something called vasa nervorum. And that's the distinction. If you go back and think anatomy when you looked at the bones, you had the jugular foramen and the carotid canal. Arteries, and you'll see this in the heart, maintain their shape because of elastic fibers. That's the blue stain. Veins have a scant amount of that. So when we see a vein post-mortem, it's relatively flat. The jugular foramen is sort of like an irregular shaped open, where the carotid canal is distinctly circular, much more so. That's where the distinction is. Veins are known as capacitance vessels. Since they don't have all that elastic stuff, they can expand. How else are they going to take blood out of you? Right? Just, start pumping and do this. What's going to happen? I have to go tomorrow morning for blood tests. It's easy. Some of you guys do venipunctures, don't you? Yes. If you're going to be adding contrast, yes. If you don't know, that's fine. I thought you would. I mean, when I've had scans done, it's usually whoever's doing the nuclear imaging does that. You feel like a toaster oven. You're gonna feel warm. I've seen this movie already. Voila. I'm just checking. Okay, so here we are. Common factors: the intima, endothelial lining. That's it. There's a little layer of, in the arteries, they have, because it's sufficiently large, you have that subendothelial layer that's there. And then you're going to see when we look at arteries, we start to get, notice there's elastic here in many arteries, and elastic here. So you have elastic associated at the outer portion of the intima, smooth muscle, and then you have more elastic here. And then you have the external portion, which is mostly collagen fibers that are there. On the venous side, you have the same internal lining. Depending on the size, you have that subendothelial connective tissue. You have the muscular layer, which is proportionally always less. Veins always have less muscle than arteries. Veins always have a thicker externa than arteries. Those are consistent because those veins have to stretch. They don't need as much muscular tissue because it would make them less stretchy, but they need something to hold it in when they expand in size and volume. So that's a consistent finding. You're going to see more of it. When we get to the capillaries, they have a basement membrane, which is usually a protein and maybe some connective tissue layer. So fibers, and as you can see, it's a lining cell here, a lining cell here. They're kind of just one next to the other. Like you made a sheet of lining cells and you just rolled it into a tube. Thinking of a food thing with that. Like you're having a party and you roll up cold cuts and stuff like that. Get the toothpicks out. Nice, maybe some a crudités tray. I made some really good Swedish meatball sauce last night. Oh, so easy. So here we are again. This is the distinction. Arteries, typically, you're going to see the elastic artery, the muscular artery, and the arterioles. And they give you an idea of dimensions. Typical diameter, 1.5 centimeters. It's more than a half an inch for an elastic artery. They have a large amount of muscle and they have a large amount of elastic tissue. The lining is the same. And you can see the amount of external or collagenous tissue. When you get to the muscular arteries, radial artery, femoral artery, brachial artery, typically about 1/4 of an inch thick that are there, of less elastic and dramatically more muscle. Notice there's always more muscle, smooth muscle, than there are the outer fibrous tunic. And now look at the arterioles. Look at this. You have 37 microns. That's extraordinarily small. That's 37th millionth of a meter. You and I, to maybe make up the lead of a pencil, you'd probably have to have, I don't know, 100 of those, maybe more, next to each other. So, but notice, even with that lumen, that opening that's there, you have a fair amount of muscular tissue. That's why they're the vessels we call resistance vessels, because there's enough muscle. The muscle here is not, it would take an immense amount of pressure. It'd be impossible to do an elastic artery. We used to operate with tourniquets in the extremities. To do lower extremity, to operate on a knee, to do a knee replacement, we'd have a tourniquet at the thigh cranked up to somewhere between 350 and 500 millimeters of mercury. When you have your blood pressure taken, it's about, for women, it's about 180 to 220 to 200. For men, it's about 200 to 220. You know how tight it is then. Imagine 350 to 500. In the upper extremity, you'd have that tourniquet up to 250 to 300. Let's say if you were doing it here and operating on an arm or hand. So it gives you an idea of how much pressure it takes to take one of those arteries. Here, the lumen is so big, you can almost close it completely. That's the way you redirect blood flow. It's there. On veins, yeah, here, capillaries, there's nothing. There's no elastic, there's no muscle. Just lining cells with a little bit of stuff holding on to them. Venules, tiny veins, again, no elastic tissue. And as you can see in veins, the fibrous outer layer predominates proportionate to the amount of muscular tissue that's there. So it gives you an idea of what they're all about. Elastic arteries, muscular arteries, and arterioles. So the elastic ones are the first one. Those are the ones. Another name is conducting. They're all about the dicrotic notch thing. The aorta, pulmonary artery, carotid, subclavian. Big, big vessels. Elastic is found in all three levels, mostly the media. Substantial smooth muscle, but they don't vasoconstrict. The muscle is there, okay, when it's stretched and it rebounds, and that's associated with the elastic, and it holds its shape. But it's not affected by sympathetic nervous system. It doesn't change the diameter of your aorta, your pulmonary artery, your carotid arteries. Don't change when you're in fight or flight. They don't. Pressure reservoirs, that's that recoil or rebound phenomena, continuous blood flow, even between beats. So it's not like the blood flow stops when the heart doesn't beat. That's the whole idea. They lead into muscular. Most of the other named arteries are muscular arteries or distributing arteries because they take it where it's supposed to be. Now look at the dimensions, okay? An elastic artery, if you're looking at the aorta, index finger, maybe your thumb, probably more like your index finger. By the time you get now, because they're smaller than you think, by the time you get down to distributing arteries, let's say you're in the brachial artery where you would take blood pressure with a blood pressure cuff, pinky size at best. It's more than you think. They're there. Coronary arteries, much smaller. Now you're into the pencil lead area. They're considerably smaller. Some probably larger, maybe like the girth of a ballpoint pen, or a little smaller. So their thickness is in the media with lots of smooth muscle, but less elastic tissue. Yes, there's elastic membranes that are there, so there's elasticity, and they do and stimulate them, and they can constrict. Where arterioles, as they get smaller, they lose a lot of the tunics that are there. Mostly, then you have smooth muscle endothelial cells, but they control the flow into the capillary beds. That's where the resistance is. That's where blood pressure is controlled. Capillaries are a little bit different. They're so small that only a single red blood cell can get through. And a lot of times, red blood cells have the remarkable capability, we talked about that a little bit in the blood, that they can fold a little bit. They can bend a little bit to get through narrowing areas. They have that capability. One cell is about the entire circumference. Okay, they're stabilized by certain kinds of cells that will play a role with the openings. So understand that layer of lining cells is held together by something called mostly tight junctions. Tight means watertight. And so you're going to see in continuous capillaries, most of the ones going into your muscles, things like that. Most going into the organs are called continuous capillaries. Not all. And it's like the cells are together and there's tiny little openings. You can just get some light going through that. And that's how stuff goes in and out. The kidneys, the openings are larger and they're controlled by these pericytes. There's specialized ones that control the openings to allow more or less flow, and they have a little additional perforations. They're called fenestrated. A fenestration is an opening. In surgery, when we use a fenestrated drape, let's say we're operating on somebody's knee, you have a sterile drape that has a hole in the middle. You put the hole over the knee, clamp it, and operate through that. So fenestration is another name for a window or an opening or a hole. And then in the liver, much, much larger, big openings, because the liver processes blood that's filled with stuff that you just ate or drank. Nutrients that have to be broken down, materials that have to be modified, fats that have to be, there's all sorts of stuff that's coming into the liver by a special system that's coming from your small intestine, mostly into the large intestine, a little from the stomach. And so we have capillaries everywhere except for cartilage, no blood supply. Epithelia gets it by diffusion. The cornea and the lens of the eye. No capillaries need apply. So the capillaries are about all the exchange of all those things. So they have, as I said, tight junctions and tight, I always think watertight, with intercellular clefts that are there. Here's the continuous ones, nearly everywhere. The ones that are unique are here. There are two areas where they're unique. One is in the central nervous system, meaning the brain and the spinal cord, particularly the brain. And the other is in the male, in the testicular capillaries. Those create barriers. The most famous of them all is the blood-brain barrier in the brain. So certainly if someone has an infection or a condition, medicines that work on the brain have to be fat soluble, because those capillaries have so many tight junctions, stuff can't get out. Water soluble stuff has to go through the membrane itself. Plus they have another layer of cells around them, called astrocytes, that augment or help out that blood-brain barrier. And you probably learned about those, or at least touched on them if you recall in AP1. A little bit similar story, except just the nature of it's just more tight junctions. In the male, sperm are produced starting at puberty. The trouble with that is that the sperm would not be viewed as self. Your immune system would view them as invaders. So if there's been someone was struck by in a football play, a guy stuck in the groin, and they got bleeding from testicular damage, you could have a pretty profound immunological reaction. Totally enclosed with tight junctions, no cellular clefts. Normally all the rest of them are like this. They have little clefts that are there, again, about the diameter of a blood vessel. These pericytes can sort of pull and tug on the clefts, make them a little more opening, and really very interesting. Fenestrated, typically kidneys, sometimes intestines, sometimes endocrine glands. Swiss cheese-like, if you will. I personally prefer Gruyere, but it's too expensive. Any Gruyere fans? You want to take a good dish and make it great. Take French onion soup. You can use Swiss. Tastes great, but Gruyere. It's sort of like it's Swiss cheese on steroids. Increased permeability, and they have usually something that controls the opening. And you can see them there. Those are the fenestrations, a little bit different. So there's different kinds of that. And when we look more at that in the kidney, these are very few tight junctions, big clefts, very large lumens. Spleen, because it filters your blood. Adrenal gland plays a role so that epinephrine and norepinephrine get in there. Bone marrow, because all the blood formed elements we learned about, red cells, white cells, platelets can sort of sift through that area, and the liver particularly. the flow is not as rapid, lots of white blood cells to destroy invaders, and it's a very, very interesting system that's there, and that's what it will look like going into the liver, let's say. And capillaries themselves, okay, are between the very small arteries and the very small veins. So again, it's a continuous system. Every so often you'll have what we call an arteriovenous fistula, where an artery and vein will go directly together. Normally they're not a problem unless they're in a problem area and you have to do something about it. Okay, so flow of blood through a bed from an arterial to a venial. It starts at something called the terminal arterial, and that branches into capillaries. And then eventually they all come in. You see the illustrations you're going to be talking about. Okay, so flow is controlled by the diameter of the flow coming in. Okay, and all sorts of local things are about it that are there. And this is kind of what it looks like. Normal flow. So right now, the blood flow into your digestive system looks just like that. When all of a sudden you leave here and I'm going to go for a workout, I'm going to go take a walk, whatever I'm going to do. I'm going to exercise for a while. That's what will happen. Going to the gastrointestinal or genitourinary tract, it'll just stop the blood flow and redirect it elsewhere where it's needed, like muscles or your heart. That's what it will do. So that will just effectively bypass that area because you just don't need the circulation there. It's not going to close off blood flow to all of them. It's just going to diminish them substantially. And in this chapter, when we start looking at the physiology, you'll see a little bit more intensely. So additional features, for instance, in the intestines. Channels that directly connect the arterial, so it's a bypass. We call it a meta-arterial. It's controlled by something called precapillary sphincter. And it's so, for instance, in the gut, let's say when we're not going to be utilizing it, we still have a little bit of blood flow, but it goes by way of this shunt. So it goes from the artery to the venial. As long as these sphincters, these little circles of smooth muscle, are active, they don't allow the blood in there. So you can bypass areas where you don't need to use them. And then everything else is veins. And the boss has a question. So veins carrying the blood back to the heart, and they start at the capillaries. At the end of the capillary, this is the start of a venial. The venial will get into larger veins. So the venials, again, mostly lining, a little bit of tissue that holds them together. Very porous, lots of stuff can come in there. And then they begin to increase in size. And so your hand is like that. Your foot is like that. All the veins coming, let's say, from your fingers are coming into like an arch of blood vessels. So a lot of times you'll hurt your pinky and you'll see black and blue all over. You'll stub a toe and see black and blue over a much wider area because there's a lot of interconnections. They're all networked together. They flow in from a lot of areas that are there. Okay, thinner walled, larger lumens. The externa is thicker. Okay, and that's why they're called capacitance vessels. And at any one time, about 2/3 of your blood is in there. We'll leave it there and we'll pick that up. Not today in lab. We're going to pick that up on Tuesday in lecture. I will send you the study guide. And I'll have that stuff for you to look over. I should have all of it together. Thank you.